station of the skills fair is going to go over both the Larry tube and the high-risk airway. A Larry tube is used when a patient's had a laryngectomy. A total laryngectomy would be the removal of the larynx and separation of the airway from the mouth, nose, and esophagus. This is a very radical procedure, and it makes the patient into a total neck breather, where no airflow is from the mouth or the nose. They may place a voice prosthesis to allow airflow into the esophagus. You also may use a red rubber catheter to keep the puncture patent at times. But when we really see the patient up on the floors, either they're in two situations. One is where they have already had the procedure, just newly had the procedure, and they have a laryngectomy tube in, and the laryngectomy tube looks like this down here. Right here is what a tube looks like, and they'll have also on it a heat moisture exchanger. So this is removable, and they change it every day. This can be removed after the patency of their new neck breathing airway, and they are able to remove that, and the stoma remains for the life of the patient. The nurses are caring for the HME every 24 hours or visibly soiled. This is just for our information. We're not responsible for this. But if we do go in and we see a patient's having a problem with the Larry tube, what you need to do is to, you can suction that area. We can clean anything that would be preventing it from being patent. And again, help the nurse and instruct the nurse on what they should do. If the patient our main role is patient safety. So let's say that the patient has shortness of breath. Are you going to try, I've come into the room and found a nasal cannula on one of these patients. They're getting absolutely no supplemental oxygen in that situation. What we need at the bedside is an ambu bag with a pediatric mask, always at the bedside. SPD, I have been assured, always has those because of the laryngectomy patients. What you would do in the case of an emergency is you would remove the Larry tube if it's present. The ambu bag does not connect to that, and then you would take the ambu bag with the pediatric mask, turn the mask sideways, and bag the stoma. There's also going to be, this is all pretty new, laryngectomy signage at the patient's bedside for communication in emergencies. There should also be laryngectomy equipment at the bedside. Very soon after these patients have their laryngectomy procedure done, they're taught how to take care of their laryngectomy. And so what they would do is teach them how to clean it, teach them how to clean the HME, and all those sorts of things. So when you're teaching a patient those sorts of things, it's very important that we have the expert at the bedside. The expert is not us. We need to understand how to do that. The expert is speech. So we now have a process, and this is out of a sentinel event, where an RN admits a patient that has a Larry tube as a Q4 airway management. How this will happen is the patient is in their assessment period, and they check Larry tube, yes or no. If they check yes, what happens is that a bunch of orders will drop, one of them to us and a consult to speech, which is new process. It will come under the heading of airway management. It's very important that you do not DC that order, and you will chart under airway management, and you're going to have a choice between a trach tube and a Larry tube. So now, if you have any questions on that, please come see me, and I'm happy to go over things with you. We're going to